Hello, everyone. And to stay busy before lunch, we've decided to go across the border, not to Italy or Switzerland, as we could be tempted to do from Chamonix, but rather we're going to go farther into Germany. And we're going to look at the approaches adopted by Germany and the results that they've attained to improve efficiency in the healthcare system. Cocteau said that a French man is an Italian is a French person that's a good-humored French person, and a German, in terms of health, is a French person who is reasonable, who knows how to take their drugs appropriately, or not at all? Or are they Europeans like others, or are they worse? Let's see with our colleagues. And we've got Francesca Colombo, who's the head of the health division at the OECD, Daniel Barre, who's a member of the management committee at Allianz Private Health Insurance and a former federal minister of health for Germany, and Thomas Paul-Macaire, who is the PhD and a clinical director and chief physician at the Clinical Center Ingolstadt. I manage a very international group. I'm the CEO of Allianz Global Assistance. We have a French root with Mondial Assistance, and we're a subsidiary of a German insurance group. Let me start with Francesca. How do we measure efficiency? What is efficiency? What is the quality-price ratio? And what's Germany trying to achieve? And what are they achieving in terms of efficiency as seen by the OECD? And secondly, how do you deal with the problem of affordability?
French in good mood and Italian in good mood. So I'm very happy to be here. So obviously, I don't want to spend too much time really on the measurement issues of efficiency, value for money. I think it has also been mentioned in the first panel. It's what you get out of the system relative to what you invest in terms of resources into the system. Now, there is obviously a huge debate about whether we measure the right outcomes. The typical things is life expectancy, both at birth or age 65. Other indicators of whether you get good results for health. We know very little about the outcomes from the perspective of patients. And on the other hand, you have the investment that you have, the resources that you put into the system. So how does the Germany really compares? Well, their approach is very much one which prioritizes as a notion of value, so what you get out of the system, having access. So the access really, it's absolutely by all indicators that you can look at, really very, very, very good. Very few out-of-pocket expenditure, a large availability of services into the system. There is literally a very little unmet need for both for medical and for dental services. So excellent. But if you look then at the ratios between the outcomes, so the life expectancy or healthy life expectancy to the costs, well, perhaps Germany is not doing as well as some other OECD countries in the fact that it's a rather expensive system. You know, one of the countries which have the highest spending as a share of GDP and also in per capita terms, but with average outcomes, life expectancy is just above the OECD average, but below some of the good performing countries, whether it's Japan or even France and Italy, and some issues about really the efficiency on the hospital sectors and some other sectors. So mixed results, I would say.
And in terms of affordability?
So affordability is linked to the value for money. I think for the moment, Germany has done quite well, so you don't really find issues of large deficits, for example, in the insurance system. The question is much more in terms of the future. I mean, the pressure are high, they are there, they are linked to aging populations and the need to reconfigure the systems, but also to some of the very expensive technologies which are coming to market and which are challenging, frankly, not just Germany, but more broadly OECD countries, France as well. So I would say, for the moment, Germany has done quite well in that respect. The challenge will be much more into the future.
Daniel Barre, est-ce que vous partagez cette...
Daniel Barre, do you read this in the same way in terms of efficiency of the health system?
The Federal Minister of Health in Germany, the colleague of Madame Turenne, I learned one thing, that it's easier to explain to people they have to pay more for healthcare than to explain them they get less in healthcare as a politician. And I think it's a political, it's a society decision, what they want to have. And in Germany, we have a good access to the healthcare system, and the people love to be free to choose their own doctor, they love to be free to choose their own insurance, they love to be free to choose their own hospital, they love to be free to choose their own therapy. And that's contrary to efficiency, of course, but I haven't found an ideal system in the whole world. So it's so complex to find an efficient system with a very good access. And if you mention Japan, sorry for that, but it's typical OECD point of view. You are very critical, of course. Perhaps it's your role, but you can't compare Japan to Germany because perhaps the outcomes, the indicators are not comparable because it's not only the healthcare system, it's the way of living. And Japan has another way of living, so perhaps the recommendation of OECD would be for the Germans to eat more sushi, then we have better indicators of what it is. It's not only the healthcare system.
What's wrong with sushi? Bon, le régime crétois. Le régime crétois est donc.
Yes, we will talk about diet perhaps this afternoon, but if we look at the details and of the different levers, obviously Germany has a federal republic, so it has a federal tradition that's quite historical. What is the role of the Länder and the regionalization of the healthcare system in Germany?
Different Länder in Germany mainly have the duty to organize healthcare in hospitals. Only the hospital sector. They do the plans for the number of beds needed for the different specialties and so on, and which is a very special way of financing in Germany, is they are responsible for the investment part of the remuneration. And this has led in the 50 years ago to a huge disparity between those countries like Bavaria, where this still functions quite well, so the country can pay these amounts of money necessary for renovation and investment in hospitals, and in others like North Rhine-Westphalia, where this is no more possible. This is one of the bigger problems. But I want to also say something to Francesca. If you take those very simple outcomes like life expectancy, you miss a lot which has to do with life quality. And if a person, for example, in a country like the United Kingdom, has to wait for hip replacement for 1 year with very heavy pain in his hip, he will probably not live for a shorter time, but he will have better quality than in our system, where the access is very rapid. But this very rapid access, of course, has the problem that sometimes procedures are performed which would not really be necessary. So this is the other side of the coin. Closer?
Yeah, but if you doesn't work, yes. So still, I think if you even put Germany relative to France, and I don't want to defend the French system because there are a lot of things that do not work in the French system. However, the system in Germany is more expensive, and the outcomes, even if you go a little bit drilling down beyond life expectancy,
It's not more expensive than France.
in per capita
of GDP. It's the same amount.
in per capita terms is more expensive. So in life expectancy, completely agree. It's a very gross indicators. Definitely there is a need to have better indicators, but there are some. I mean, the quality of healthcare, for example. For Germany, and to be fair, also for France, it's very quite mixed feelings, very mixed results, very high hospitalizations for diabetes, for example, which is a condition that should be treated really in primary care. So that is quite indicative. It says that possibly we should do better into the primary care system. That's definitely an area. Another area where there are room for improvements is about case fatality, so mortality, 30 days after a heart attack. So the cardiovascular disease burden and mortality is particularly high, but somehow we don't have good quality indicators, after there is a heart attack. So I completely agree, and I'm the first one, and the OECD the first one to say to be very careful with broad indicators of life expectancy. we do have a number of much more drilling indicators of quality. We lack, and that's something that we want to take it much more at international level, we lack good measures of quality of life from the perspective of patients. So, for example, if you have a hip replacement, and I'm mentioning hip replacement because Germany has got the highest volumes of hip replacements in the OECD countries, does a patient has pain after? Is he or she able to walk? Those are really important outcomes from the patient's perspective that at the moment we just don't measure internationally. There are some national efforts, but internationally we just don't measure.
Donc, pour revenir au sujet
To come back to the subject of regionalization, Thomas's first comment referred to medicine with several speeds, with some Länder that have better quality than others. What is your opinion, Francesca, in terms of regionalization of healthcare in Germany?
In that, there is obviously an issue which is, I would say, a general problem of systems which are decentralized, which is about capital decisions. So decisions about hospital investment and so forth, they're often taken, at more decentralized level. And there is an issue then on rationalizing and managing the overarching number of hospital and hospital beds that countries are internationally struggling with. I mean, the health system of OECD countries have in a way, got it wrong for the health needs of the population right now, because they've built systems which are very much hospital-centric, about episodic care instead of continuity of care, about cure instead of prevention. And right now, obviously, the epidemiology has changed dramatically. The needs are different. There are multiple chronic conditions that requires something much more about continuity, primary care, prevention, and so forth. So the hospital capacity overarching, in Germany, of course, but as I said, it's an issue also for other countries, is a lot. And countries which have a decentralized system has sometimes struggled to make decisions about rationalizing this capacity. Denmark is a good example. They've really made a huge reform in the hospital sector that centralized certain treatments in a very limited number, if not one hospital only, for guaranteeing high volumes. And they have closed some hospitals, reoriented them to be more long-term care facilities. But this was done very much at the central level, working with the regions, but the central level.
Donc la régionalisation, vecteur d'inégalité.
So regionalization can create inequalities and a lack of optimization, because sometimes there's competition and no national optimization. That would be the conclusion to what you're saying?
Being closer to what the people want, and that's something not to dismiss. It's a really important one.
Alors, votre opinion sur la régionalisation?
I'm a big fan of.
What's your opinion in regionalization?
I think the regions are so different. If you compare Chamonix to Paris, you have different demand on healthcare systems. So it's not a good idea to organize all the healthcare system in a national view. In Germany, I think it's a good idea that the national state is only responsible for the regulatory framework, and then it's the self-administration, for example, of the associations of hospitals, of the associations of the insurers, of the associations of patients, and the associations of the doctors, and they decide how to set incentives, how to finance the system. And I'm not a fan in Germany, of course, that the Länder, the regions, are responsible for the infrastructure investments of the hospitals. And they are not doing it, as you mentioned, Thomas. But so the idea not to focus on a national view, then to give more responsibility in the regions, in my opinion, is a good idea. And to get to better competition, to get to better infrastructure in the region for their demand.
On a un débat éternel sur centralisation.
So it's an eternal debate on centralization and decentralization. Another eternal subject that everyone debates on is pricing, the TAA or DRG in English. What's the use of DRG in Germany, and what can you say about the result? Someone from a hospital, or Daniel, as you like? Was
Mr. Plöger from Ameos, a German hospital group here, and he said that the idea of DRG financing was to reduce the number of beds in Germany, and that was a success. Now we can say that was one of the success stories of the DRG system. But in my opinion, the DRG is not a prize. It's still an administration system, and in my opinion, we need more competition. We need to get, it's very difficult, but we need to get to a DRG system as a prize where the hospitals could see what they get for a treatment and where they can make their own decisions, for example, to invest in infrastructure and others. But the DRG system in Germany is very complex. It's more complex than in Australia, where we copied it. So it's perhaps as typical the German way. We copy something, but we make it more complex. And that's the difficulty of the DRG system. The idea to pay the same treatment with an amount is a good idea, but perhaps we have to be more flexible and to have more a better incentive for financing the system with a better DRG system than what we have now.
Francesca?
So if we look at the data, what we see is that the introduction of the DRGs has led to a reduction in the average length of stay, which is obviously it's an indicator of efficiency, similar to what is seen in other countries. On the other hand, it has led to increase in volume, particularly for elective surgeries. And when we look at the data for Germany, there is definitely an issue of very high volume. And internationally, the volumes of activity, the discharges, are incredibly high in the system. So there is definitely a question about whether DRGs alone is the only tool to be used, or whether they should come with a combination of some other mechanism, and whether DRG has been used just as a reimbursement mechanism, or could be used in a way that some other OECD countries use it, also for budget decisions, for setting prospectively what could be the overarching budget, or having, in a way, a sort of an idea about the overarching envelope that should be taken. So in a way, DRG is a very, very important tool, used extensively. It's like some 80% of the hospital costs in Germany are covered by DRGs, which is higher than other OECD countries. Could be used even better.
We'll get into that, but yeah, Thomas.
I think the usefulness of DRGs is very much depending on the medical context. DRGs are very good for reimbursing procedures which are highly technical, which are also highly predictable in terms of costs, and where the technical part is accounting for at least 40 to 50%. If you have situations which are medically much more complex, for example, in multimorbid older people or in psychiatry, this comes very quickly to an end of usability, because there the variability in costs can very badly be predicted by variables known at the entrance of the patient to the hospital, and this makes it usable for certain parts very good and for others very badly.
Alors, dans une table ronde précédente, on a un peu polémique.
Previous roundtable, we had a big debate on whether the introduction of the DRGs introduced a market economy into the healthcare system or not. But one of the objectives was to ensure that all hospitals were paying the same thing, were paid the same thing for the same act, as Daniel said. So hospitals that had costs higher than that price would go out of business. And so there is a competition for economic efficiency between hospitals. And then people thought that some hospitals might specialize on certain acts where they had the best margin, and then it could induce spontaneously a system of specialization, which responds to what Francesca was saying, the fact that the sanitary map would be more rationalized. I remember a few years ago in Germany, they were talking a lot about the fact that they published the economic and quality performance of hospitals so that patients could choose the good or bad hospitals, and those who had good and quality performance were not only under economic performance because their margin went down, but also patients would go to the good hospitals. Do you see this type of market dynamics occurring in Germany?
because the problem in Germany is, as I'm now working for a big insurer in Germany, and we like to advise our patients, our insured persons, to go to a hospital which have good quality indicators, which have a good quality report. But the problem is the patients are following the general practitioner recommendation. And it's very difficult to get into this relationship. And a lot of patients are looking on a hospital in the quality, they are not reading the quality report or not comparing hospitals. They're asking how's the food, how's looking, the room, what is the feeling, and it's not the medical treatment, and that's the problem. We need competition on the medical treatment, and the DDRG system was very successful to get to better, I think, process management, to get to better efficiency in process, so the people don't have to wait too long in the hospital before treatment, but as to get to better, in my opinion, performance measurement, that would be, in my opinion, the next step of the DRG system, but it's very complex, and we have to explain it to the patients because they have to understand what is the indicator and what is the difference between hospitals and medical treatment.
As a medical doctor, I would like to add that the problem is that patients obviously will never follow these kind of approaches because they are not in a situation of a typical consumer who wants to buy a car. This person is very prone to read a newspaper which compares the new Mercedes to the new Audi, but the patient is in a very different position. He has also the sense that he is not able to make a rational decision. He's seeking for paternalistic advice. I know that the word paternalism is not very much liked now in medicine, but finally this is what the patient wants to. He wants a person he can trust in, and he says, you have to go there. That's why he follows the recommendation of the practitioner and does not look into these complex quality reports.
Yeah, no, I agree entirely. I mean, internationally, what is done by the patient is very much what the doctors say, and obviously there is a very important trust relationship between the patients and the doctor, which makes that in the countries that do have similar type of rankings, and there, I mean, the United States has got a number of them, you have the situation which is quite well known about Bill Clinton. When he needed to undergo surgery, he chose a hospital which had very, very below average indicators of outcome. So, I mean, and this is an informed person, is somebody who obviously is well educated and so forth. So there is an issue about these indicators, this ranking, which are very difficult to construct and very difficult to interpret for the patient. That said, the health system remains too much of a black box, and there is a huge need to have much more transparency. Much more transparency about results, about outcomes, with all the difficulty that it comes. We can argue whether having ranking of hospitals is the best way to do it. Some countries might do it differently. They show, for example, and it's more as a tool for hospital themselves, they show how a hospital compare to the average, for example, of other hospitals in the country. And Canada is a wonderful system of indicators of performance of hospitals, where each hospital can really drill down also to procedures and understand how they're positioned relative to their peer. There is information which is publicly available for the public, but there is information which is available only for the hospital managers, administrators. And in a sense, there is a tension. One is the goal of choice and making sure that patients can choose and how best to inform that choice. The other goal is a quality improvement and a performance improvement goal, which is something that might require also managerial tools, and where maybe like the choice of patients is not necessarily the best mechanism.
So changing topic, pardon, si on change de sujet,
Changing topic here. What about the impact of new technologies on the German healthcare system, the use of information systems, telemedicine, big data, new technologies in the broad sense, especially with telemedicine, which is a very interesting subject that everyone's interested in every country?
Telemedicine is growing very rapidly. We have some areas where it's already well established, for example, treatment of stroke. We have very good stroke units now, and they are networking more and more, and all the radiological assessments are now done in telemedical ways. But the final use of this will go far beyond such sophisticated techniques. This will go into the everyday life of the patients by connecting them at home to their treating physicians. By even in my specialty in psychiatry, we more and more try to implement web-based or telemetric psychotherapy approaches, which are, at least for the mild to moderate cases of depression, highly effective, much more effective than to go every second day to a psychiatrist. And so I think there lies a lot of medical and even economic progress in this area.
Et comment ces transformations alors sont acceptées par le...
So how are these transformations accepted by the healthcare professionals, doctors, and what about the economic impact? Do you have any feedback for that?
Maybe Daniel knows.
We hope to get to better care in Germany by telemedicine, because we have the problem of shortage of doctors in rural areas, and telemedicine could help us to get patients to better access to specialists, for example, and to get to better network treatment of hospitals and ambulatory sector. The problem in Germany is the discussion on liability. So if a doctor is still responsible if he's not in front of the patient, that's a problem on the legal side. And we changed the law when I was in the ministry, but it's still an issue which has to solve. But in my opinion, something else is very important. As I'm now looking at the manager of a private insurer in Germany, I hope, and I'm very optimistic, that the new technologies, the health apps, could help us to get to better compliance and adherence of a patient. Because our problem is not diabetes, is not obesity, because we know how to treat it. We know that it's not a problem for an insurer. It's not very expensive if the patient is following the recommendation and the instructions of a doctor, but he's not following yet. So perhaps those apps, those technologies, could help us to get to better compliance and adherence of a patient. So in the demographic challenge, we will see that the increasing costs for diabetes or other diseases would not so high because of those technologies which could help us to save money.
Yes, I agree. I mean, the potential is huge. It's there. I mean, if you look at the big data revolution in a way, you can really dissect the good outcomes that this could bring, both in terms of surveillance of disease, in terms of management of clinical conditions by the doctors, in terms of system management, reduction of waste, and even in terms of research. Potential huge out there. Issues to realize that obviously some of the legal aspects that you mentioned, but also the privacy, which is obviously a particular tricky ones, and I think Germany also it's very tricky to manage. It's not just a matter of building the trust, but also have even legal systems that do protect the privacy on individuals, but at the same time allow the use of data and the revolution to reap all those benefits which I mentioned. And striking that balance is not easy. Privacy regulators tend to be a little bit more conservative. Health policymakers look at, I do need to have this data being used into the system in order to just drive the efficiency, in order to improve surveillance and so forth. So that's a particularly difficult areas to square with. There are other things that can be done more quickly. The e-prescription, for example. I think some countries have done tremendous advances in the use of e-prescription. I think Germany is still lagging a little bit behind on that. That would be yeah.
The problem in Germany is we haven't trusted the free market in IT technology. We thought it's better to build up a national state level system of IT technology in healthcare, and that was not a good idea. It was because of the data protection. I'm a big fan of data protection, but if we want to get to better success with this data, you need competition, you need flexibility to use this data, and the idea to start with a infrastructure IT IT infrastructure system for whole Germany was not a good idea. We are still waiting, and it was a decision in 2002, I remember, or 2003. So still waiting for the system. I can't accept. But I fully agree that we have to do better for prescription of medication plans and so on. And I'm optimistic because we have all the data. As a private insurer in Germany, it's another situation than the sickness funds. We have all the data because the patient is giving us all the invoices, but we are not using the data, and that's I can't understand, because we could give a lot of advice to the patients. We could set better incentives with those data.
Oui. Enfin, sur ce sujet,
Yeah, concerning this subject, if we talk about compliance, the use of data, it's something that we've been talking about forever. But the world is changing. I think an increasing number of people wear Fitbits, so many people don't worry about the fact that their mobile phones are acting as policemen. You know, people are more accepting of these technologies, I believe, and we'll talk about that. Anyway, I hope the world is changing. Let's change the subject. What about the medication envelope? So payers have been negotiating medications with pharmaceutical companies. It's more decentralized in relation to countries that have a set price. What approaches can we have to increase the budget in Germany, and what are the results? Because Germany is doing better than others. Does it have good recipes, good solutions? So a positive word about Germany, please, Francesca.
That is done well, and some things that do not work. That's very typical OECD answer. So the expenditure on pharmaceuticals is quite high in Germany. They have particularly high prices at market entry of new pharmaceuticals. That's really quite high. They have, however, a very good penetration of generics, much higher than you find in France. And they have a system of reference prices, which is not applied just to the active substance, as is applied in a number of countries. That it's really the reference price for bioequivalent is really considered for the active substance. In Germany, it's considered for the therapeutic areas. So it's a little bit much more of a broader, and once there is a reference price, that sets in a way the cap, which is going to be reimbursed. And so that is working quite well. But you know, the overarching budget envelope for pharmaceuticals is quite high. I think is driving by the high cost of particularly the specialty drugs and the new drugs. Utilization in some areas it's also quite high, and it goes back to the issues of high utilizations. Hypertension, anti-hypertensions. Are really quite high utilization, and also for diabetes, anti-diabetics are also quite high.
Well, in the past, Germany was the pharmacy of the world. It's no longer. It's now France, Switzerland, I don't know. And we had a situation which I would call a paradise situation for a pharmaceutical company, because until 2010, it was the pharmaceutical company who's setting the price, and the insurers has to reimburse it. So that was not a competition system, because they could set the price for themselves as a pharmaceutical company, and the system has to pay. It was very expensive. When I started in the ministry, we paid more for pharmaceutical products than for the ambulatory sector, and that was, in my opinion, not acceptable. So we changed the system. Now it's still fast access for new pharmaceutical products. That's the wish of the people, in my opinion. That's still necessary to have fast access of new products, but they have to prove that they have an added value. We call that they are better than the current standard treatment. So we are now looking fast access in the system, but then they have to the pharmaceutical company has to negotiate a price with the association of the insurers, and then if the new product has proven that there is an added value. I think that's a good system to still have fast access, but then they negotiate a fair price. We want to pay for for development. We want to pray for better treatment, for better product. But I think it has to be proven and not to be said only.
I agree that this development has been very good in the last years, and we need that to really limit the expenses. As always with these things, it tends a bit to go too far, because the way the evaluations are made now are in reality are very restrictive. So for some new medications, it's somehow a bit questionable why this institute does not recognize an added value. But as always in these things, this can happen, and this will, I will say, we will achieve a new equilibrium in the next years.
But the National Institute in Germany on Quality and Efficiency in Healthcare System, which are looking in the data and improving it, they are working together with NICE and your HRS, no? Institute here in France, and I think it's still uncharted waters. So we learn a lot in sharing experience, and it's you're right. They made mistakes, but. If I compare it to the system in the past, it's better to go this way and to learn on the way.
Yeah, and I think on the pharmaceutical is again, it's going to be a hot potato for the future. I mean, some of the new specialty drugs coming to market and looking at prospective studies on what is coming out with the advent of precision medicine and so forth. We're going to see really smaller groups, target groups with particularly high prices. There is a huge debate internationally about the innovation system in health. Do we get the right innovations? We don't have innovations as yet. On dementia, we are lacking the developments of new antimicrobials, with antimicrobial resistance really becoming very high. So perhaps there's not enough incentives for some innovations. There are some incredibly cost-effective drugs coming to market. Hepatitis C has been really the one that came very much into the picture, but with incredibly high prices. And the question is, what's the right level of remuneration and return on investments that society is willing to accept also for the pharmaceuticals? But then there is a panoply of other, innovations that come with incremental higher prices, not necessarily added outcomes for the patients. And again, that rise the question of what do we do, with that, and how do we increase the overarching transparency? Huge issue for debate of the future.
Ça, c'est le sujet d'une table ronde à part entière.
That's a very good subject for a round table. In the United States, we're seeing results-based payment, prices that are changed when reimbursement costs have been refunded, and approaches to reduce development costs and to have a kind of phase 4 in real time. There are approaches that are being set up, but of course this is, it's the eternal question, the cost of development, patients. We haven't really talked about continuity of healthcare and private practices. So what about confidence as well, very quickly? What do you think about efficiency and effectiveness of the German healthcare system compared to the French healthcare system? Where is it better to be a patient?
Francesca.
We'll start with Francesca, because I think it's going to be interesting.
I'll repeat. I think both systems are very high performing. I mean, we're talking about being a bit negative, but we're talking about among the best systems in the OECD countries. So it's something to remember. There is the issues definitely of access, which is absolutely stellar in the German system, and that's a value that the Germans have considered as particularly important. There is the issues of perhaps the efficiency and value for money, where things can be done, particularly in this notion of moving from volumes to value, really. That is something important, and about rethinking, reconfiguring the system for the future, which requires a different configuration of service delivery. Less hospitals, much more focus on the coordination that we didn't manage to cover, on the role of prevention, which is the first item to be cut in moments of crisis, and much more on the role of generalists as well, which are reducing. I mean, if you look at the number, they're reducing in numbers.
Une Allemagne plus focalisée sur l'accès et
So Germany is more focused on access to hospitals than Danielle.
If you ask me, I would prefer to live in France. I love the French lifestyle. I love France. I'm a big fan of France. So living in France is very good. But as I'm looking as a patient, I prefer to stay in Germany because I love that my children could visit me in my hospital.
Okay. Thomas?
So being kindly invited to a French conference in this wonderful surrounding, I never would dare to say something against the French healthcare system. But I'm also not actually in the position. Francesca knows much better. The only important difference I can see from my personal medical field, from psychiatry, is that the way French handles this, in particular in an economic way, is much less prone to innovation. They're more strict and more stable in that. And our ways to handle this high accessibility and so is a bit more prone to progress. This is the only difference I really see.
Thank you very much. Merci à tous.
Thank you very much to everybody. Thank you very much.